My name is Maria and I'm one of the midwifery lecturers based here at BHL. And I'm just going to do an introduction to midwifery in our skills lab. So this is the lab where our midwifery students get the opportunity to practice some of the essential midwifery skills that they need when they go into the clinical areas. So I'm just going to do a demonstration about the main ones. So I'm going to start with the abdominal palpation, which is one of the essential skills that all midwives need to practice, and this is a way that midwives have to monitor the baby's growth. So we've got a dummy here which simulates a pregnant abdomen, and we just teach the skill of abdominal palpation. The measurement then is plotted into a customized growth chart, and that gives an indication on how well this baby is growing, and if there is any deviation from the norm, that then initiates the referral pathway where the midwives then will refer to a sonographer for an ultrasound scan. So we not only teach the skill of how well this baby is growing, we also teach the skills of knowing which position the baby is laying inside the mother, whether it is an appropriate position for the baby to be delivered vaginally, or if there is any deviations, then we would refer to an obstetrician. So to perform a measurement, we do have to feel the abdomen. So we palpate with our hands and we position the highest point of the uterus, which is called fundus, and the midwife will position the tape without looking at the measurements to get a true measurement, and the top of the tape goes at the highest point of the fundus, and then we need to locate the bony part of the pelvis, which is called symphysis pubis, and that's the end of the measurement. So we would measure right to the symphysis pubis, and then we turn the tape around, and that gives us the measurement. So this abdomen measures 28 centimeters. So then that would get plotted on the chart, and that chart is worked by gestation of the baby and according to the BMIs and previous babies that this mother may have had, and then that will give us an indication on how well this baby is growing. So then now we are going to demonstrate with our lovely Lucina, which is our lovely lady. It's operated by, so it's like computerized, and this mannequin delivers babies, and then we can also practice different emergencies that we may find either during the intrapartum or the postnatal period. So any problems with babies delivering or any malpositions, we can also practice the skills of delivering babies that suffer from shoulder dystocia, which is when the shoulder gets impacted on the mother's pelvis. This mannequin will allow us to do that. So now we are going to demonstrate how this lady will have a normal birth. And if you can see now that baby is rotating, so that's telling you that this baby is now ready to be delivered at the shoulders. So if we did set the monitor, if we did set the mannequin to have a shoulder dystocia, then this baby would not come out as nicely as it's come out now. And then the student midwives have got the opportunity to practice different skills to help the baby deliver, which is very important when you go into the clinical areas, because you need to be able to practice these skills before you actually go into the clinical areas and practice alongside the midwives. Obviously nothing beats the real thing, I don't think, but you know, this is a good opportunity for us as lecturers to be able to practice the skills and to be able to do scenarios and to be able to do a lot of simulation. So by the time that the midwifery students get to the clinical areas, they've already got that motion in their heads of what needs to happen and what is my role as a midwife to ensure a safe delivery of a baby. So this baby's head is now delivered. So obviously we will wait for a contraction, and probably mom will tell us that she's got a contraction, and she will just be spontaneously pushing. And we very gently do downward traction. We wait for her to push. We don't pull unless there's a contraction, because that would be that could damage the baby's nerves around the neck. So we always work with mom, and we always wait for mom to be ready to push. We can encourage the mom to push if we have to, but we always have to work with the contraction. If she's got an epidural and she's not actually feeling the contractions, we can actually feel the abdomen to see if she's having a contraction. That's another midwifery skill that is very, very important. So she's now having a contraction. So if I ask her to push, she should push. And as you can see, the shoulder is visible. And then we would pull very gently. We will pull the baby onto her tummy. Push. Push. There you are. And then we would put the baby on mommy's tummy. And if this was a real mommy, she would be holding a baby close to her chest. And then obviously she would be crying or really happy that this baby is out, and everyone in the room would be really happy. And then we keep the baby close to the skin to ensure that that helps babies' thermoregulation. So we do know there's a lot of research done about skin-to-skin contact and how it helps the bonding and the thermoregulation of the baby. And then what we need to do is just gently palpate the cord, and we do not cut that cord until it stops palpating. Obviously, if there was an emergency in terms of the baby showing signs that needed resuscitation, then obviously we would cut and clamp and then take the baby over the resuscitator to perform basic resuscitation on this baby. In a real scenario, we would wait until the cord stops pulsating. So we wait until the cord is actually sending extra hemoglobin up to the baby, and then we would cut and clamp. And then if the lady has decided she wants what we call a physiological third stage, so physiological delivery of the placenta, we do not administer any drugs. We wait for that process to happen naturally. If, however, the lady has consented to a little injection called symptometrin, which is an oxytocin-based injection, then the midwife will aid the delivery of the placenta. So we would cut and cord the cord, we would administer the oxytocin, and then we would wait for the placenta to be delivered. So I'm just going to move the baby over, pretend that the baby is now cut and clamped, and then the midwife would very gently feel the tummy to ensure that it's still contracted. So we need to make sure that the uterus remains contracted and that there is no heavy blood loss down below. And then we would, with our hand, we would gently support the uterus, and then we just do very gentle traction. And if we feel any type of resistance, we wait. Because if we feel resistance, that means that the placenta has not separated, and if we were to pull, we could actually cause a lot of damage to this woman. We could actually bring the uterus out with us, which we don't want to, because that's a major obstetric emergency. So again, the midwife will again feel the tummy, feel the abdomen, feel the uterus, make sure it's well contracted, and then again, supporting the uterus, we would do gentle traction, and as you can see, that is now moved slightly. So we carry on, and I can actually, on the top of my hand, feel that placenta coming away. As you can see, the placenta is now coming out, and I always have a little dish underneath to make sure that I capture everything. And it's very important when you pull the placenta out that you check that the placenta is complete and that all the membranes are complete. And then after we've delivered the placenta, we need to check whether this lady will need any suturing, as she had a tear. Not all women have tears. Some women will deliver with nothing, no damage down below, no trauma down below. But it's part of the midwife's role to ensure that there is no tears and that this woman doesn't require any perineal repair. There is so many other skills that we practice throughout the 3 years of midwifery, but I think the ones that are the most relevant for this event is what I've shown you so far. Obviously the mannequin is amazing. She does lots and lots of different things, and we can actually set her to simulate a postpartum hemorrhage, which is another of the emergencies that some women will have, which is bleeding after giving birth. She can have, she's got settings to for you to practice when moms are septic. There are settings for moms you can practice when she's extremely unwell to the point that she requires ITU care. So that's a really good tool to have to practice the skills. And I hope you've enjoyed it.